Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Before we begin today's episode, I just want to take a moment to thank all of you out there for your support of the show. I've been receiving numerous emails and messages lately about how much people are enjoying the show and the content and the guests, and it means the world to me to hear it. I'm honestly having a ton of fun doing this. I hope that comes through because I absolutely love podcasting and learning and bringing you really cool content that I know is helping colleagues and helping advance our profession. People often ask me the best way to support the show. One way is to download the episodes. A lot of people don't know this. I had no idea before I got into this, but the algorithms online only track downloads. They don't track listen or listeners. So it's super important to download the episode. And again, if you can do that on multiple platforms, even better. Another way is to share the show with others. If you hear an episode you like or a guest you like, share it with someone else so they can benefit from that content as well. And that really helps us spread the message of the show. And lastly, if you feel we've earned a 5-star review, or if you have any comments you want to make about the show, please do that as well, as it really helps boost our show. So thank you again. I sincerely appreciate all the support and everything everybody is doing to help grow this show. And I promise to keep working hard to bring you great content and great guests. You'll also notice during today's episode that there's a bit of a break about an hour in, and it's because my guest, Dr. David McIntosh, had a patient that he had come in, and so he had to run out real quick in the middle of it, but he was amazing and generous with his time, and we coordinated back up, and since he's in Australia, we had to kind of work on the times a little bit there, but we were able to meet back up a little bit later and record the last bit of the episode. So if you notice a change in the tone or the positioning or what Dr. McIntosh is wearing, that's why we had that happen. But without further ado, let's move on to today's show. I'm super excited to have Dr. David McIntosh with me as today's guest on the Doc Podcast. David is an ear, nose, and throat specialist with a particular interest in pediatric otolaryngology, airway obstruction, and facial and dental development. He has over 30 years of experience in managing pediatric sleep disordered breathing. David's an adjunct associate professor of otolaryngology in Queensland and a fellow in the Royal Australian College of Surgeons. He's published 3 books, Snored to Death, Don't Ignore the Snore, and his most recent book, which is really, really outstanding, A Parent's Guide to Pediatric Sleep Disordered Breathing. And I know from talking to many of you, you've read most, if not all of them, a lot of the people listening to this show. He also lectures internationally and is a true expert on the topic of the interplay between otolaryngology and dentistry, which is one of the many reasons why I am extremely excited and honored to have Dr. David McIntosh with me on today's show. So with that, I would like to welcome Dr. David McIntosh to the Doc Podcast. Welcome to the show, David.
Thank you so much, mate. And look, thank you for that introduction. I feel very humbled.
Well, a lot more I could have said there. You've had amazing accomplishments in your career. And actually, why don't we kind of start with that as people know who follow my show. I love the stories of my guests as well. We're gonna dive into some deep content as well on the science side. But before we do that, maybe just a bit of background about you and then how you got on this journey that's very focused on airway. If you could touch on that as well, please.
Yeah, absolutely. So there's a whole lot of stepping stones, and just to give the whole background. So when I was at university, let's go back to there. Mm-hmm. My side gig to pay the bills was teaching kids how to swim. So I got very used to dealing with kids, interplaying with them, getting them on side, getting them to do things that they didn't want to do, and just really just working at their level. And that sort of just had a foundation that, wasn't the intention at the time.
Okay.
But it served as a foundation getting into ENT and then the huge specialty that it is, really just gravitating towards, the pediatric side of things. And to look at the adult side is sort of how the sleep apnea story really starts. So, I sort of gravitated towards kids because of the teaching them how to swim. but I gravitated towards the Airway because of an experience that I had with our training program. And it's one of those things where you're in the right place at the right time. And in Australia, sleep apnea in terms of ear, nose, and throat involvement was pretty rudimentary, and pretty, just basic at best. But we had one of the guys that went over to Stanford and basically spent some time there picking up some understanding techniques and the like for adult sleep apnea, looking at expanding what ear, nose, and throat surgeons can do for the same. And brought that back to our training program. And our training program really was the only one that really had a good focus on sleep apnea, albeit the adult version at the time. And it was around about that time in history where we started to realize that these kids were having the same sort of problems.
About when is this, would you say? Ish?
I can pin it to, if I do the math, around about 2001, 2002.
Okay, great. Thank you.
Okay. So that's sort of when that started to permeate in. And initially we were following the bandwagon of kids, and it was just all about sleep apnea. The kid had to stop breathing at night for it to be a problem.
Right.
And as that time went by, there was these little scatterings of papers that came out. And one of the pivotal ones came out of Chicago, where they were looking at kids with sleep apnea, lining up to have tonsil and adenoid surgery, but in the process, they got assessed for ADHD. And there was a huge high rate of ADHD diagnoses that, fulfilled the criteria, which 12 months down the track had pretty much all gone away. So that was like, hang on a sec, are we going down, a pathway of mistakes here? And then it was probably in 2012, there was the Karen Bonuck paper.
Yeah.
And that was the one
I was thinking as you're talking about that. Yeah, go ahead, please.
Yeah. And that's where they looked at 11,000 children in the first 7 years of their life in development.
Yep.
And they used parental surveys to basically look at, was the child having trouble breathing at night? But they didn't focus just on sleep apnea. They also incorporated snoring and mouth breathing. And that's where we started to see a bit of a spectrum issue, because the kids, regardless of whether it was mouth breathing, whether it was snoring, whether they had sleep apnea, and these children weren't fixed, they were observed. So out of that 11,000, there was about 2,000 that were diagnosed with sleep disordered breathing. And those kids ran different pathways. Some of them, when they got it early or they got it late. Some of them, when they got it, it went away or it hung around. And they were able to basically break all those little permutations into groups and then say, look, how did that group go? And how did that group grow? And the long story short of what they found is that the younger it starts, the worse the long-term outcomes. And the worst outcomes are not relevant to whether it goes away or not. So during these early childhood foundation development years, if there's interruptions to the breathing and that causes interruptions to the sleep, which, people have to realize that's actually two problems. You've got a breathing problem and you've got a sleep problem. That's actually two problems, not one. And collectively, that's really bad for brain development. And the knock-on effect for that is that these children are having trouble with their learning, their behavior, their concentration, their emotional regulation, and the like, years and years after they've so-called outgrown the condition. So that was a big sort of wake-up call in that respect. And then the next sort of pivot point that sort of just put the icing on the cake came from the US with the CHAT study, and there's also in Canada the child studies, where they looked at a huge number of kids, but they said, all right, we're going to fix some of these kids now and we'll leave the rest alone. And basically the kids fell into a couple of different groups again, and they looked at it, and long story short, the kids that were found early and fixed early did the best. So that's kind of, how I fell into that arena and why I'm such an advocate for it, because I think we know that, the science takes a long time to permeate into the mindset of medical people. It's sort of 10 to 20 years. And, that Karen Bonuck paper, that's 2012.
Yeah.
The Shervin paper from Chicago is 2006. And, when you start going down these rabbit holes and you start rewinding in history, then you start realizing, hey, David Gazal was doing surveys in kids at school for the bottom 10% of kids in their school gradings. And then when those kids got fixed, they were no longer in the bottom 10% of their class. And then we rewind way back to 1800s, And we got, ears, nose, and throat didn't exist as a specialty then. It was just all part of medicine. But we got things, flying left, right, and centre, where childhood educators are raising concerns about snoring and mouth breathing kids. The dental profession is starting to say, hey, hang on a sec. We're seeing all these really bad jaws and so forth, and these kids can't breathe properly.
Edward Engel, the founder of orthodontics, he said in 1907, of all the causes of malocclusion, mouth breathing is the most potent, constant, and varied in its results. I mean, that's such a great point you make. Yeah.
Yeah. So we start going down this rabbit hole, and and this is the big problem in terms of, as you led into, like ear, nose, and throat and dentistry. Like, surely if ever there was a marriage made in heaven in terms of healthcare professions, it's got to be those two. We're in the same neighborhood. We're looking at the same real estate.
Yep.
Okay, maybe we're looking at it from different perspectives and so forth, but at the end of the day, there's such a massive overlap, and it's just a fantastic opportunity for collaboration. Because we know, and this is the science. This isn't some crazy guy on a box yelling to the crowd wanting attention. We've got the science. We know that kids turning up to an ENT clinic with breathing problems, the malocclusion rate's 60%. We know that kids turning up to an orthodontist, obviously with the premise being malocclusion problems, the airway problems, it's 80%. Now, there's a whole range of reasons why we can have one or the other. It doesn't have to be just it's be all and end all.
Sure.
But we've got a huge number of kids with two problems.
Yeah.
And I think we really need to move past the arguing over the chicken and the egg and what causes what. Because at the end of the day, it's kind of like the kids fallen into the swimming pool. They don't know how to swim. They're drowning. And one group's arguing about how to teach them how to swim, and the other group's arguing about how they fell in the first place. And meanwhile, the poor kid's drowning.
Yeah.
So this is where we just got to basically just take a pause. It doesn't matter what causes what. We've got two problems. We need two solutions. And if you're going to have two solutions, you've got to have teamwork.
Yeah.
So that's kind of the backstory, which I'm sure we'll fill in a few blanks as we go, but just to give an idea of how this all played out.
That's so awesome, because that's why I love hearing people's stories, because you went on this journey and people see you where you are today, this hugely successful pediatric ENT with all this knowledge. And you went on a journey where you were trying to figure this out and trying to learn. And I always find that really helps the younger docs, or even the more senior docs who are just more inexperienced in this arena, to realize none of us just woke up one day with this knowledge. We all had a journey. I just had a call with someone who's going to be coming on the show in a couple months. And we had a similar type of conversation of, like, we had this aha moment of, like, wait a minute, we're noticing as we're expanding these patients, the moms are asking us, you think that, like, not snoring because of the expansion? Do you think they're doing better in school? Like, it seems like it's really coincidental. And at the time we're like, I don't know, maybe. But then you start getting more and more incidents of it, and you start saying, maybe there's something to this. And then you start looking into the literature and into the data. And why do you think the orthodontic, well, I guess two parts to this question, I can state confidently, a large portion of the orthodontic community worldwide is very opposed to that union of us with the medical profession in terms of working with the ENTs for Airway. They think we should just kind of leave that to the physicians and stay out of it. And would be one part is why that you think that is. And the other part of that is, are the ENTs saying the same thing about the orthodontist? Like, leave us alone. This is our thing. I mean, is it both sides?
Well, I think from the orthodontic point of view, I think the problem comes down to dogma and mindset, because by acknowledging that there is an airway problem in association with an orthodontic problem means having to revise what you were taught and what you've learned. And that's a challenge if you've been doing it for 20, 30 years and some upstart comes along and says, guys, and that's very confronting in terms of, you mean I've been wrong for 20 to 30 years? No, that can't be right.
Right.
So that starts to sort of breed into the rest of it then, in terms of the, airway's got nothing to do with orthodontics. And like I said, who cares? I mean, who cares why the kid fell in the pool? We can see they can't swim properly, and you want to teach them how to, it's like, no, guys, let's just forget about that argument, because we can have that argument 1,000 times. And you know what? At the end of the day, the kid's still got two problems. Like, who cares who's right or wrong? Like, it's such a pointless use of energy.
Yeah.
In that context. because the pushback is, well, there's fixing the airway does nothing to fix the orthodontics. Well, I can show you papers where it does. I can show you papers where the crossbite and anterior open bites and all these other things that ENTs aren't supposed to know anything about or talk about gets better naturally, spontaneously in a cohort of children that can then breathe and sleep properly.
Yep.
So, look, I don't know anything about orthodontics, but I think getting better regardless of why is pretty good regardless.
Yeah.
Whether there's, just the natural history that some kids just get better because that's the magic of orthodontics, or not. Well, look, I don't care. These kids are getting better.
Right. And Harville proved the converse of that in the studies in the 70s with rhesus monkeys, where he plugged their noses in purebred rhesus monkeys with zero malocclusion, looked at them at 6 months and then 2 years, and they had tremendous alterations in the craniofacial growth and development, which was the type of alterations you see and just described: anterior open bites, vertical growth, transverse deficiencies, high vaulted palates, right? We know it both coming and going. We know that these are intertwined.
Well, so for those not familiar, Harvold was a person that did some research where basically, like you said, he got the monkeys, plugged up their nose and forced them to mouth breathe, and then charted their facial growth and development over time. And it ticks all the boxes that we see in mouth breathing kids. So you can call that a coincidence. But then when he unplugged them, these monkeys started to breathe better, and then they started to revert back to their normal patterns that you would have expected. So you have an intervention, an outcome, a second intervention, and a reversal of that initial outcome. Look, that's one hell of a coincidence. Let's be honest. That's all it must be. Yeah. So we have that, in the background of what's going on. So, and then you asked me, do ENTs, object to orthodontists being involved? Look, I've got to be honest. I think that most ENTs are still rather unaware of the extraordinary things that can be done with maxillary expansion. I can remember being at a very big world top level pediatric ENT conference, and one of the persons associated with a huge study, massive study, tens of millions of dollars of study on kids in airway, put up a slide of an expander. Now I knew what that was. It's like, oh yeah, that's an expander. And he said, look, I'm starting to see more of these. I don't know what it is. I think it's got something to do with straightening the teeth. And I was just dumbfounded.
Wow.
It's just like, this is a real problem. And it just highlights, why there needs to be even more collaboration, because, we have, surgeons looking inside mouths that have been through dental clinics that have got these expanders in, and they just put it down to, its primary reason is to, make the teeth straight. And they don't understand how the narrow maxilla leads to compromised nasal passages, which exacerbates nasal issues, and it also opens the door for what can be otherwise minor ENT problems that can actually manifest far quicker. Because if you have a little bit of an allergy in a big nose, well, you'll probably get away with it. But if you've got a little bit of an allergy in a compromised nose, you're going to trip over sooner. Likewise, with the maxilla not coming forwards, the whole nasopharyngeal space is smaller. So those adenoids volumetrically don't need to be anywhere as big to take up the real estate to be causing a problem. So look, I think, you sort of just to rewind, because I was reflecting on my journey when you were sort of saying something about, doing my own research. So I can remember in around about 2008, thinking I was the first person in the world to ever even know what was going on, because it was like, hey, all these adults, we're giving them mandibular advancement splints for their obstructive sleep apnea. We're correcting basically a mandible position that is underrepresented. Well, that's what we're seeing in kids that are mouth breathing. And then I walked through a dental clinic one day, and there's a research article written by an orthodontist, and it's written years ago. And I'm like, this is everything I thought I'd worked out, and this guy's already saying it. And it's like, I'm not reinventing the wheel here. I'm rediscovering it.
Yeah.
It's kind of like it's been tucked away and so forth. And all of a sudden, I think I've found it. But no, you go back, someone's been here before.
Yeah.
And it wasn't just that guy, but like I said, you rewind to the 1800s and so forth. And that's the beauty of the resources we've got now. I'm old enough to remember when there was no such thing as the internet.
Right.
Okay.
You, me both.
Yeah. All right. So, and I can remember the rudimentary stuff that we had when it came out, which was, game changing. Now, it's just, the level is extraordinary. So you can go and find something, from 1891 just at random about some random person who's long dead and buried, who wrote one little, paper describing a few case series of his that might have been 20 or 30 kids, describing everything we're talking about. And that's just eye-opening that, history is a great teacher for those that choose to study it.
Yeah. And the way this evolved and then devolved was really, really interesting to me, because in orthodontics, there's a lot of times I'll mention something, or I'll be talking about it online or even at a meeting, and people are quick to say, oh, this is fringe, or this is this whole Airway fringe thing just to make money. And in 1979, the Moyers Symposium at Michigan, I was shocked. I looked at the people who were there. It was on Airway and malocclusion. There were ENTs and sleep physicians. And I didn't even know that our professions were even communicating about this stuff back then. And there were general practitioners, and they were having this symposium to talk about this. And then you fast forward 20 years to the late 90s, and it's like, can't find any, it's like we're not talking about it all of a sudden. And you know what else is interesting, David? We read in our residencies, in ortho residencies, we're reading those Harvold studies. We're reading Coracini, and we're reading Melvin Moss and functional matrix. I mean, we're studying this stuff. We're reading McNamara and some of the work he put out in the 80s, talking about this being a jaw size problem, not a tooth size problem. Talking about Schwartz in the 60s with Gratzinger, that you need to develop the mandibular arch. I mean, to a lot of orthodontists today, you even say the words mandibular expansion and they just tune you out. They just think you're it's quackery. And I'm saying we've known this for 60 years. And as you alluded to, we're doing it well before that. It was just, Schwartz kind of had his name put on it because he was one of the first ones to develop a really predictable way to deliver this care. But is it the same in the ENT area, where they know about this and this is something that they're cognizant of, but it's just like you were saying with the orthodontist, and I agree with you, change is hard, doing it differently than you were taught is hard? Or is it that in the ENT arena, they're just it's not even on their radar as much?
Well, I mean, the orthodontics, it's starting to creep in here and there. It starts with one, and then it starts to get disparaged, and then there's only so long you can disparage something that's staring you in the face, and you have to reconsider. And then you start to get a little bit of momentum and movement in a certain direction.
Yeah.
But by far, it's met with resistance.
Yeah. Interesting.
And again, it really just comes down to, there's a saying, it's easy to fool someone, it's harder to convince them they've been fooled. So whatever you've basically been introduced to first up tends to be your foundation as to where you're at. Yeah. And you can translate it across anything you want to think of. You can translate it about your food preferences, your religion, your language, your culture, what you think of your own country that you live in. And, the objective, evidence will come at you left, right, and center, but you will still hold, firm to what you were told from the beginning. And, it's not until people from the outside that can see and go, this don't look right. And they start saying things that you might start to, see where things are at. But, in the big scheme of things, it's, it's like everything. It just takes time to change. And when those changes come about, it's done in a way that, the people that were looking stupid 20 years ago, get reviewed and honoured, as a legacy, to what they were saying back in the day. But, I think there's another saying, the difference between crazy and genius is time.
Yeah, love it. And I completely agree. It does take time, and I'm very encouraged by the younger docs I teach and train and coach, and they get it when you show them. And I think it's exactly what you just said, right? They haven't had to learn something that they now have to unlearn. They don't have to look back at this body of work and question it. They just have to look back at maybe some of their education to that point and think, well, wish this was taught to me earlier, but I still can incorporate it and learn it now. And that's a big difference. That's a big, people I don't think talk about that enough, is that part of the reason I think people are so resistant to this is exactly what you just alluded to. And that is dogmatism, patterns, habits. It's ingrained in us when we go through our educational process, right? I mean, we come out and this is all we know. And as you said, whether that be religion or politics, it's the same concept. We believe something, and to unlearn that and then not only unlearn it, but then have to look back at all the time that we lived it is more than I think a lot of people can take.
Yeah, well, there's this thing called cognitive dissonance, which is basically which is basically, despite the fact, plain as day, for anyone else to see, what's going on is not what you think is happening, you still refuse to accept it.
Yep.
And they've done, plenty of research, things like that. I can remember one study where basically, a very simple thing, they have a 2 lines, which is longer, and they set the person up so they have 10 subjects in the room, but 9 of them are plants, and 9 of them say the shorter line is the longer one, and the 10th person, who is the real subject, about half the time they'll go with the crowd and just want to fit in, even though plain as day, that short line is not the long line. So then there's multitude of psychological studies and so forth where they look at these things. So it's part of our programming to want to fit in. That also plays into it as well. So I think it's just time, and it's great that you're getting the young docs in and exposing them to it. And then it's kind of one of those things, like it's hard to ignore when it makes sense. If we were saying that broccoli causes malocclusions, we'd be like, well, I think how the hell are we going to prove that? Right. But we go, well, airway problems and malocclusions go hand in hand. How do we know that? Well, let's look at our clinic today, guys. Let's take a roll call. Let's ask these parents how many of these kids are mouth breathing and snoring. That's low hanging fruit for us. We don't have to know why. And let's just come back and revisit. And then you can do that. You've seen 30 kids in the clinic that day. You compare notes, and 25 of them are mouth breathing or snorers. And you go, that seems like a lot.
And we're not even asking. So in most training programs in the US, they are not incorporating sleep questionnaires or even sleep questions. And that's one of the things I want to bring up in your newest book, The Parent's Guide to Sleep Disordered Breathing, because one of the things I'm such a stickler on, and I'm constantly borderline preaching to the residents about, is diagnosis and treatment planning, and don't just jump to the treatment. It is so important, even in cases that look simple, that you take the time to go through a certain process to get that diagnostic information. Because as you said, if you just look at the malocclusion in our case, or in your case, the larger tonsils and adenoids, turbinate hypertrophy or lymphoid tissue hypertrophy, you can just look and be like, oh, great. Okay. This is large. I've just got to cut it out, or I've got to prescribe this medication or whatever it is. We could look at that malocclusion and say, oh, their teeth don't fit and their bite is off. Let's go ahead and just fix it. And you really hit on in your book the why, and you talk about the clinical history. And this was in the context of when a parent goes to see the ENT, what to expect. But I say the same thing for the orthodontists. They should be asking about if there are episodes of stopping breathing, sleepwalking, sleep talking, night terrors, teeth grinding, sweating at night, persisting or relapse of bedwetting, general energy level first thing in the morning, morning headaches, educational issues, concentration issues, behavioral issues, energy levels with physical activity, any suggestions of hay fever, asthma, prematurity or reflux, and general health issues of any other kind in the background. So I know most orthodontists out there, and I'm not being critical, I'm just trying to raise awareness on this, they're not asking these questions. So much so, we just had a patient in the residency yesterday that she was super retrognathic. A lot of times we feel like these patients are maxillary protrusive, but as you know, and I know it's not super common that you have this super protrusive maxilla, even though we kind of label it as that. It's oftentimes the mandible's retrognathic. And so she comes in, it was a transfer. The faculty who had been seeing her is no longer there. And they had given her the options of surgery, mandibular advancement surgery. They'd given her the option of that, or premolar extraction to camouflage the class 2, or using, in this case, aligners and TADs to distalize the maxillary dentition and retract the incisors. So this is my first time with the patient. The resident did an awesome job in briefing me on the history and that they were doing this. And she showed me the case and said, it's been going on for about 2 years now. And we're not making a lot of progress. We're kind of driving things back a little bit on the top, but she's still got a ways to go. So I sit down with the patient and I start looking at her occlusion. I said, do me a favor. I said, slide your lower jaw forward for me till you get closer to your top front teeth. She did. And I mean, her profile just balances out. Her throat length lengthens. And I look at her and she had darker skin, and you'd see these dark circles under her eyes, which I said to the residents, if you see someone with darker melanin in their pigmentation and you see dark circles, those are real allergic shiners, or just that venous pooling is severe. And her eyes just had what I always call tired eyes, right? They just looked tired, and she had kind of an edge to her that I was just sensing she just was frustrated. So I sat her up, and I knew that no one had, it's not the resident's fault. She just got the case transferred to her too, but it wasn't a protocol at the time that they should be asking any airway questions. So I sat her up and I said, tell me about your breathing when you sleep and when you're awake, when you breathe with your mouth open. And she's like, oh yeah. And I said, anyone ever told you snore at night? Now, again, for a middle-aged woman, I mean, it's not the most comfortable thing. I don't want to be like, yeah, I snore like crazy. So she kind of hedged around a little bit and said, well, I don't know, maybe a little. And I said, have you been ever told by a significant other that you snore at night and kept anyone up? And she's like, well, actually, now that you say it, my husband has been telling me, especially lately, that I'm snoring like crazy and it's keeping him up. And I said, okay. I said, how about energy? Are you tired? Do you get tired during the day? She's like, I'm exhausted. Now she's 47. She's like, I am exhausted. And I said, how about irritability? Do you find that you get more irritable? Are you hyper irritable during the day? She said, I am always on edge. And the resident, because I teach them about this, she's like watching me do this. So the patient looks at me, she goes, how did you know this? And I said, there's certain things that I recognize in the face. And she's like the dark circle. She beat me to, she said, like the dark circles under my eyes. And I said, well, to be honest with you, yes, that is one of them. I said, the position of your lower jaw is very far back. Your tongue doesn't have space. And I said, and again, I knew they had talked about oral surgery as an option with her. And so kind of fast forward, we get through this. And now I talked about surgery. Now the patient is thinking, who had refused surgery before, when it was presented to her a couple of years ago, she's now thinking, well, if this could help my airway. And here's the crazy thing, David, she says to me, so this shows that we aren't doing our job. Our patients are having to research this on their own. She says to me, what about those things that like posture you, starts making the motion with her jaw at night to sleep better? Would that work? Which tells me instantly she's been online Googling to find out about snoring, right? Without a doubt. Like, would she know about this? He's like, could I wear one of those at night? And I said to her, I said, well, we'll talk more about that. I said, they work for some people, and yes, it can be helpful, but if you're in treatment already and we want to, we can talk to an oral surgeon here, we could maybe get you more definitive care, but we've got to do some more work on our end to figure some things out and so forth. So I said to the resident after, I said, this is why we ask these questions in the beginning, because the patient, and they documented it well, she refused surgery. But I said, why do you think she refused it? Because no one told her that it could help her with her breathing if we got the mandible forward. And that's such a classic example of what you talked about in your book. And we don't do is taking that history. If we knew from the beginning that this woman couldn't breathe, maybe we wouldn't have been trying to camouflage her malocclusion and treat her teeth, and we would have tried to treat her.
Yeah. And in the process, actually done a favor rather than actually made the breathing problem worse.
Right. Because she did say that. She said it started during, said it has gotten worse, especially lately as they've been driving things back.
Yeah, exactly. So, look, I think one of the challenges from what I understand, and you've got better insight than I do, is that orthodontic residency and training is like it's 3 or 4 years, and you've got to get a certain number of cases in and out real quick because that's your timeline. So I can understand in that rush for the exit that you're trying to find these cases and then you're trying to fix them, and that tunnel vision develops. But unfortunately, in that process, you go past the things that you've highlighted, and then that also then sets up patterns for life. Because it's like it's got that
conditioning
to tick and flick, and again, it's not a criticism.
Thank you.
We just got to put it into a context of understanding that you're not going to see your failures as an orthodontic resident. You're just not. You're going to see it 20 years later, and even then, you're probably not. Because they're going to go back to their general dentist, and it's the general dentist that's going to be babysitting them down the track.
Yep.
that's going to start to notice things going amiss. So, the ones that have been retracted that are then, seeking a mandibular advancement splint to, compensate again. So, and again, I think it's a tricky gig, and we can't make the world perfect, but I think the point of, I think, these sorts of meetings of the mind just need to be raising the awareness and to say, what, let's accept that at the end of the day, I'm an ENT and my expected knowledge on orthodontics is zero, and that as a dentist or an orthodontist, your expected knowledge on ENT is zero. And with that expectation laid down, let's see if we can do better than zero. And that's really an individual choice, and it's an individual journey. And the thing is that once you see things, you can never unsee them.
Yeah, for sure.
Okay. And I think, as you're doing, the earlier you've exposed it, so that resident that you're talking about, their whole career has changed from that moment.
Yeah.
Because they've had that aha moment where they've gone, oh man, my supervisor called me out. And it's like, it wasn't like that, obviously, in terms of, what was the playing down. But it's kind of like, sometimes that's the way you learn. You just learn by someone just pulling you up and going, well, let's just hold up for a bit here. Are we really looking at the whole story as to what maybe, could be on the table here? And it's okay. We've all missed things. We'll all, continue to do so. But
on that point, I actually told the residents, because I had a lecture with them literally right after that. And I said to the residents, I said, I'm not pointing fingers here. I said, because if you go back into my earlier years in practice, I did the same thing. Like I literally took cases just like that and did that. So, it's just, now that we know better, we have to do better. We can't just keep continuing down that path.
Yeah. Hey, look, for the first 10, 15 years of doing this gig, I was convinced that all I had to do for these kids is take out their tonsils and adenoids and they were cured for life.
Oh, really? Interesting. Okay.
Oh, yeah, 100%. Because we're not taught anything different.
Yeah.
Dealing with nose allergies and deviated septums, wasn't even on the radar. It was just tonsils and adenoids. And you just did tonsil and adenoid surgery and they were fixed and that was it, done forever. And clearly that's not the case. But, it's only clear when you know that it's clear. Right. So we collectively can and should throw ourselves under the bus for the benefit of those that we, have coming through, just to show that, at the end of the day, we're all human. We're all going to have those moments, but what's important from those moments is the change.
Yeah.
These things are not career ending, but they can be career bending. And you can change course in terms of just the way that you approach a clinical situation.
Yeah.
And having those moments like you had, it's just that perfect opportunity to solidify it, so that they can they see it in real life. And and it's one of those things you actually get an enormous satisfaction knowing that from that conversation you have changed this patient's life. Okay, you can change their teeth, you can make them look pretty, you can get them Instagram worthy or whatever you want to sort of nominate as being their motivation, but you can actually change their life, change their health, change their wellness. And, you also change the relationship that she's going to have with her husband. They're drifting towards, separating at nighttime, and that can lead to separating forever, to things coming back again. And, that diabetes might be something she's never going to get now. And that high blood pressure is something she's never going to get now. Right. Those lifetime of medications that she's never going to need now. So, the way I would, I just don't get it, in one respect is in terms of professional satisfaction. Okay, look, the stuff you guys do, like the canvases you paint on, like the teeth I see and then what you turn them into, man, that's incredible stuff. Like I sit there and just go, wow, you guys have really, got it great. And that's very satisfying in its own right. But, you can add, this layer into it. And just become, this movement of airway orthodontics that, saves people's lives, as opposed to, making teeth straight. Look, that's why, people are into it at the end of the day.
Yeah, that's the why.
That's the real joy and motivation that comes from, the whole scenario. And it's very easy for those that, want to disparage it, in terms of having ulterior motives and agendas that, financial, which I know, because I know that gets thrown out there. Well, there was nothing that you had to gain financially about this situation that you've described. In fact, you'd have been better off just continuing with your treatment, because that's what you were getting paid for. Whereas you've actually gone, let's put a pause on this and let's send you in a different direction, because I think this is in your best interest. And that's the motivation in terms of healthcare.
Completely. And I say so often exactly that. The reason I'm doing this, the reason I'm having you on this show, is because I was so deeply impacted in my practice by those exact interactions that they totally transformed my way of thinking. And I say often that I was very fortunate to be a very good clinical orthodontist and made a lot of very amazing smiles. And I'm proud of that. Nothing, however, nothing compared to when you had a mom, or even sometimes a dad, break down in tears because you were the only one that figured out that their child was suffering with something more than crooked teeth. And you got them the appropriate medical care through your referrals, and you did the appropriate normalization of their anatomy through your work. And they literally, like, weak in the knees, like, sit down and have to take deep breaths because they're so overwhelmed by what you did for the child. And I've said to people often, I tell the residents, one time that happens and you're changed forever. You literally will and I say to people who are so skeptical of this, and quote unquote haters, as we call them, the people that are always, casting stones at this and saying there's no place for orthodontists in Airway, and if you want to know Airway, be a physician. I actually say to them, and people have probably seen me say this online to people, I feel sorry for you. And I don't mean that in an insulting way. I don't mean that in a flippant way. I truly feel sorry for any of my colleagues that won't get that experience, because there is literally nothing like it that's happened to me in my orthodontic practice career that is that powerful. And I've treated crazy cleft craniofacial cases and all sorts of things that I've done. It is something as simple as, and sometimes, David, it's even before I treat. Sometimes it's just in the consult room. Back to the diagnosis you were talking about. It's just like, I'm looking at the cone beam. I'm doing my Airway tour that I do with them. I'm looking at their history and what we've gathered from them. And I say, Mom, I see you say here, Johnny snores a little bit. Let me talk to you a little bit more about that, or his behavioral issues. And you start asking, and the parent just looks at you, and you get that, I knew it. I've been telling people that something's wrong with him, and it's not that he has ADHD, or it's not, that he's not smart, that I knew there was something more. And, I always say, look, I'm not here to diagnose the airway. I'm not here to treat obstructive sleep apnea. I'm here to recognize aberrations and abnormalities in anatomy and recommend you go see the appropriate specialists or physicians, or whomever it may be, for that area, allergy, ENT, et cetera. And then I normalize my lane, which is in the mouth. I normalize the craniofacial bones and get them growing the right way. And oftentimes, mom and or dad, that's going to help this patient. Again, sleep apnea is complicated. It can be due to many other things. However, before we start taking more drastic measures, let's normalize the abnormal anatomy. Let's normalize the obstruction to airflow through the nose, and then we'll see. And David, honestly, 99.9% of the time, just doing those simple things, recognizing the issue, referring it to your medical colleagues as needed, and addressing the anatomic variation in the issues, solves these kids' problems. It's amazing.
Yeah. And what you've also done, because I know there's a whole industry that tries to teach dentists and orthodontists how to build a practice, grow a practice, etc. Hey, the biggest thing is word of mouth. I guarantee you that mum went and told 5 of her friends. And go, hey, how my kid was snoring and your kid is snoring? Go and see this guy, because this guy has changed my kid and he knows what he's talking about. And I didn't even have to try.
No, you're so right. That happened so much. I never advertised this. I didn't really advertise much about anything anyway, but I never said like Airway, or never, ever. And things live online. So if anybody thinks I'm lying, go look it up. I never put any promotion out that I did this in any other capacity. I just treated the patient. That's all I did. And I just thought outside the box and looked at this differently. So one thing I hear from orthodontic colleagues is they'll recognize this sometimes. Because I really should give credit to the fact that there are a lot of orthodontists out there that are doing what we're talking about. You know, we're kind of just you know, human nature. We focus on the ones that aren't, but there are a lot that are, and a lot of the ones that are reach out to me and they say, Mike, I can't find an ENT who will like work with me here. They're just like they look it in the nose, say, oh, not a big deal. And so, I mean, what are your thoughts? I know you're in Australia. We're in the US, but what are your thoughts on that?
So look, I think first up, ENT is a big specialty. Okay, it's like saying dentistry. You know, so I've been to see the dentist. Now, technically, once upon a time, you used to be a dentist. Now, I've just insulted you. You know, if you're, if the mindset where that's likely to happen. Because you go, no, I'm not a dentist. I'm an orthodontist. You know, okay, whatever. But
exactly.
It's like, well, look, I was a doctor first, and I'm an ENT. So which one am I? Well, I get to play both.
Yeah.
Because I'm in healthcare, I'm not in ENT care. I'm in healthcare.
Yep.
And so from that point of view, ENT is no different. And the comparisons I make, and it's really easy when you start making these comparisons. Let's look at an orthopedic surgeon. All right. Now, if you've got an orthopedic surgeon that sole focus is on shoulders and you've got a hip problem, now you can go and see that guy, girl, whatever, we're not gender specific, just talking just general here. You go and see that person and the level of interest and care will be next to zero. But you can say, but I went and saw the orthopedic surgeon. He said there's not much that can be done about my knee or whatever. So it's like, well, hang on, did you really see the person that's going to deal with your problem? Or did you just went off the shelf generic? I found an orthopedic surgeon there in the office next door to me, so that's who I went and saw. Because it was just easy and convenient. So ENT is no different because, ENT falls into about different, I think I counted around 11 different subspecialties that you can have with the ENT. Pediatrics is one of them, nasal, nose sinus, cancer, cosmetic, laryngology, otol, etc. All right. There's a lot there that ENT branches into. So it's not this kind of like, canvassing someone to try and work out on going on a date with them is how I look at it. And it doesn't matter, what you're trying to do, you've got to see if you're going to be a match. And if you're not going to be a match, it doesn't matter what you do, what you say, what you want to happen. If that person's not interested in you, it's just not going to happen.
Right.
And it's the same thing at a professional level. If you're approaching an ENT who is, 99% laryngology, only deals with voice problems, wants to see the professional singers, and you bring in a 3-year-old kid that's snoring, look, it's not going to hit their radar. There's a level of interest. So the first thing is you've got to say, all right, I need to find, people that actually focus on this. And if that means that you've got to travel a bit to get to the right person, well, that's better than getting the wrong person telling you the wrong stuff. So that's part of the deal. And I think part of the conflict that from what I understand, and I'm only just an outsider, is just that the way that the healthcare system is structured over there. There's depending on your health insurance plan, kind of determines which providers are on your plan that you may want to see because they're on your plan. So you've got some coverage. And then the other thing then is that these insurance companies basically drive the clinical bus. They're the ones that set down the rules and the regulations to what they are prepared to cover. So if for example, the medical insurance organization says, well, we'll only cover tonsil and adenoid surgery in children if they've had a sleep study, and that sleep study shows that they've got moderate or severe sleep apnea. Well, that physician's in a box there that they sort of get conditioned to say, well, the only kids that I'm going to be able to fix are those kids. So your kid, they mouth breathe, but they don't snore. They're going to have a normal sleep study. There's nothing I can do for you because it's not going to be covered by insurance. And that's actually not the case. There's heaps you can do. The problem is that the insurance doesn't want to participate. And that's not the same thing. But I think that conditions people's thinking and behaviors, and then the treatment planning that goes with it is that there's sort of that background consideration to, well, who's paying the bill here? Is this parent that's got insurance about to find out that the insurance doesn't cover their kid for this procedure? then even going to, front up, and it is enormous amounts of money that you pay, in your country. I've done the math. It's actually, at least pre-COVID, before the airfares went stupid, it was cheaper to get on a plane, fly to Australia, have your surgery in Australia in a private hospital, just pay it out, and stay here for a 2-week holiday and fly back again, all included. It was cheaper than some people when you look at, what they're paying, with no insurance, and even sometimes just the copay, 5,000 copay. It was cheaper to get it to Australia and have your surgery here and fly back again than it was just for your copay. Now, look, COVID's changed that a bit because the airfares have gone up, and that math doesn't work so well anymore. But, that's, again, we're talking about conditioning and environment, and I'm saying, look, this is a perfect example where, as an outsider, I'm not criticizing what you got. I'm just making an observation.
Sure.
You got, a situation where, you've got a health industry that has to make health decisions, and part of it realistically is going to be financial. Look, these things are going to be in the mindset of the doctors as well, because they're not going to, get much throughput if people, are fronting up with, things that their insurance doesn't cover. So that conditions them to sort of just not bothering, which is not a criticism. It's just that environment. It just changes people. Yeah.
You're 110% right. That in every discipline of medicine and dentistry in our country, that is a big problem. is the insurance companies and pharmaceutical companies dictating care and what gets done. It's definitely something that bigger than you and I obviously can solve, but I love that you called attention to it, because the more people that talk about this and become aware of it, the more we can fight for this and people become aware
it's again, it's just getting that understanding, it's just like, I can't find that ENT. Well, sit down with them and say, hey, look, I'm just trying to get the gist of this. Is this an insurance thing? Is this because these kids, I've seen the science, I get the research, I respect you. You're a top-notch ENT guy. You've got a great reputation, but are your hands getting tied by the insurance company? Is that the problem that we're running into? Because if that's the case, look, I can prep the parent and say, look, there's times where insurance cover this and times where it doesn't, and this guy will definitely want to help your child, but they might have some hesitations about it if it's not going to be covered as to how you're going to feel about that. Parents go, well, I just want my kid better. And so forth. Well, that can sort of clear the air, leading up to, them seeing that ENT, because they're sort of half prepped for how the conversation may play out. And that's the important thing. You just understanding people's perspective sometimes comes from just having a chat to them. But having said that, look, the niche that I sit in ENT is very, very small. And it's sort of self-made, because I'm not dentally trained. I don't know dentistry, because it's not my gig. But I've come to realize that my work by myself as an ENT is far inferior to what it is compared to what comes from teamwork. And I've got so many people that I work with now that I was never even told or taught about through medical school, through university, through medical school, and through my ENT training. That's 16 years from the day I walked into university to the day I walked out of ENT. Nothing about working with dentists, nothing about working with myofascial therapists, nothing about maxillary expansion, and so on and so forth.
This is where I go nuts with the AAO 2019 white paper, because they say in there that the responsibility of the orthodontist with pediatric, in a minute, we'll come to the OSA versus sleep disorder breathing conversation. But for the purpose of this part, we'll just focus on what the AAO white paper says. So they all about OSA. They don't say anything but OSA. And they say when we detect an airway problem in a patient, our job as the orthodontist is refer the patient to our medical colleagues. And this is where it gets ugly. Let them tell us what that patient needs from an orthodontic perspective. And I have said from the beginning with that, I'm like, talk about punting as a profession, right? Talk about like, can we weaken ourselves anymore, and that we're just these little two straighteners running around going to school for us 11 years typically after of university, and then of undergrad and then graduate school. So are we really relegating ourselves to just that? But they don't want the responsibility. Back to the stuff we were talking about earlier in the episode. I love that you said that, because it's like, well, okay, so I send the patient to the ENT. Now the ENT's job, I'm telling the ENT that the ENT is supposed to tell me what I'm supposed to do. And I'm not saying that in an egoic way. I'm saying that is like that's not fair to the ENT. Like, why am I putting that on you? And you're just saying you don't get training in this. So again, to me, it was just the AAO saying, and I'm not saying this to disparage the AAO. I'm literally just taking the words that they said and judging them, which I have every right to do, to say, I just fundamentally disagree with that. I love what the ADA said in 2017 in their position statement, which was detect the issue, refer to your medical colleagues as needed for the appropriate care, and then you, the dentist, dictate what treatment needs. They call it evidence-based treatment to address any anatomical variations that are contributing to it. To me, that it doesn't get more complicated than that. No.
And this is the meeting of the minds, where we're each in our own are preaching to the converted here. And part of what permeates through when these things start to evolve is those frustrations that exist at many different levels. And it's really, again, just rewinds, and it's that foundation of knowledge that was first brought into someone's mindset, because you didn't know anything about teeth or orthodontics when you were at middle school, right? So everything that you were starting to be introduced to was at the discretion of the person that was introducing you to at the time. And that's all founded on what they felt and what they knew and what they'd learned, and plus or minus any upgrades to the same. So from that point of view, part of this is that word of mouth tradition and so forth. The other challenge, this is a medical school thing in the United States, is that the curriculum is, and I only learnt this last month, the curriculum for all of your medical schools is dictated by one private organisation that sets the curriculum for every university. So from that point of view, the universities have to be credentialed, or whatever the box ticking exercise is, they have to follow that algorithm.
I guess now you say that it is the same in dentistry. There's a CODA, Council on or Committee on Dental Accreditation, and they set the regulations, and you have to abide by them, or you don't get accredited. So
that makes change hard, because until the people sitting around that table say, oh, we want to bring sleep apnea into the medical curriculum, it's never going to happen.
Same with the dental.
So that's the challenge there too.
With the sleep apnea side, I was teasing that before with the story about the white paper. I didn't know until I started going on this journey. All I heard about was OSA, right? Until I started looking into this, and you alluded to it a little bit in some of your conversations before about these kids who may not have OSA or may not be able to afford or have access to a sleep lab or a sleep study, or may go to a sleep lab or have a sleep study that doesn't look at RERAs or respiratory distress, and is just looking at apneas and hypopneas and getting an AHI. Because there's really, I've learned too, there's really no standardization amongst these sleep labs in the US. I mean, there isn't. So there's no. You to say that, I've had people, my colleagues, say, I don't trust any literature unless they have documented decreases in AHI and changes in their AHI score pre and post treatment, then I don't even pay attention to it. So I used to think that way, to be completely honest. And then I started studying this a little more and realizing OSA is end stage disease. I mean, and a lot of kiddos are never, because of their hyperactive sympathetic nervous systems, and they're never going to register on this scale. So is this something, I'll let you kind of explain it from your medical side, and then I'd love to hear your feedback. Well, again, the medical community is aware of this.
They're not. It's a history flow. So we started with adults, because we hit that rewind button. We started with adults. Now, the context for adults was nothing to do with medical conditions. It was everything to do with having an excessive number of car accidents. That's how we tripped over it. They were tired from their sleep apnea. They were typically overweight, and that then set the framework for sleep apnea. It was typically male, typically obese, that was having a car accident. It was nothing to do about blood pressure, nothing about diabetes or heart disease or stroke. And, you know, when this stuff started to come through, the cardiology profession, up until probably about 5 years ago, absolutely refused to accept that sleep apnea was a contributor to cardiac disease.
Really?
They just would not accept it. Yeah. There was huge pushback. That just shows you where we've got to and where we're at now. But then we started noticing it. But the thing that we noticed in kids was, it wasn't obviously the car accidents, it was struggling at school. And that's where the David Gazelle, school survey thing came into the mix, because he basically asked, does your child snore and stop breathing at night? And they were the kids that get fixed, and they were the kids that get better.
That was in the early, that first one was like early 90s, right? Am I right on
correct,
that? Yeah.
Correct. Yep. Correct. And then we sort of bounced forwards where it was, well, we got these group of kids and they're not stopping breathing, but man, they're really struggling, like and stuff. And they're really, just struggling, working hard just to breathe. And they're not stopping. And then we sort of going, well, hey, look, they kind of got big tonsils and adenoids, because that was the historical paradigm of what we noticed. And we started fixing them, and they started getting better. And then it was like, hey, we got these kids, they're snoring like every night, like horrendous snoring. And they're waking up tired and they're struggling through the day. And we started fixing them, and they started getting better. And then we had the mouth breathing kids, and we started fixing them, and they started getting better. And that's where we really changed to the disease is sleep disordered breathing, which covers any one of those touch points. And the thing that I've has been proven time and time again is, first of all, a sleep study in a kid is unreliable from one night to the next. You'll get two different results 40% of the time. So which one do you believe? They've got sleep apnea one night and not the next. So which one's right? Well, you can't pick and choose there. And you don't do it 2 nights in a row. So, you've got a 50-50 of calling it one or the other then.
Right.
So that's the first problem. The second problem is a sleep dust study does not tell you which kids are the worst of the worst that need fixing sooner rather than later, because the offset to having an airway problem and a sleep problem is their intrinsic resilience to the same. It's kind of like, we tell everyone smoking is bad for you, because we know in the big scheme of things, smoking is very much bad for you. But we can point to N=1 of my grandfather, who picked up a cigarette at the age of 3 and has smoked to the age of 110. So what do you mean smoking's bad for you? Right. Well, that one person in the lottery of life had resilience to that exposure. And that's not to commend smoking. That's to say, well, look, you know what? We have to accept that at the end of the day, some people might get away with it, but don't roll the dice on that one. And it's the same with airway. You can have a child that has got pretty marked airway problems that is offset by extraordinary resilience. So the net effect to them is they don't seem that bad. Whereas you have a child that's extraordinarily vulnerable, where they've just got a bit of mouth breathing, just the early stages of airway problems, and that sends them off the edge of the cliff. So that's where you've got to look at what is the net outcome of this. And the net outcome goes to those things that we talked about. Are they snoring? Are they mouthing? Are they stop breathing? And are they tired? Do they have trouble with concentration, behavior, emotions, physical activity, and sweating at night, teeth grinding, sleepwalking, sleep talking, night terrors, allergies, asthma? What is this child? Presenting to us health-wise, that we really need to be looking at the big picture. And that's, so that's that point of view. To say that it needs to be driven by the AHI, well, look, the guy that invented it, Gilwino, actually, verbally, and is well documented, well witnessed, says he never wished he'd never invented the first thing, because the way it was interpreted, the way it was applied, the way it was used was not what it was. It was a research tool. It was not a clinical tool. And it's just been corrupted into the system. And I've heard these people say, look, we know that it's no good. And they go, yeah, well, look, we know that, but we just got nothing better.
It's the best we have. Yeah, I've heard that.
Yeah. It's the best we have. So, it's like you're dictating people's lives and outcomes on something that is no good. And we just, when you go back to the clinical medicine, which is what those guys were doing in the 1800s, in the early 1900s. When you read their accounts of patients, their clinical acumen was extraordinary.
Outstanding.
Far more sophisticated than what we offer now.
Because they didn't have, I've said before, because I think they didn't have the tools that we have. So they had to use their deductive reasoning powers, and
they had to think. And they had to think. And draw knowledge, apply knowledge. So
yeah. And I know you have a patient that you have to go see now, and I appreciate you've been very generous with your time and going into this. If you're open to it, I'd like to continue it. There's some other things that I'd love to discuss, and if you're open to coming back, and we can kind of pick up with this where we left off.
100%, be my pleasure. I think we're covering some great stuff here. Thanks again.
So we did have to change a little bit. David had a patient come in, so we had to just kind of sidestep that, and now we're regrouping. So if we look like we're a little different or sound a little different, we're kind of splicing this together over a couple of days. And I really appreciate him coming back to finish up the episode, giving us a little bit more time. So just to kind of on the final side of things, there's two main things I want to talk about. The first being the AADSM, American Academy of Dental Sleep Medicine, recently came out within the past 6-8 months, I think, a position statement where a panel met, and they looked at a bunch of different modalities by which people say they can help patients who are struggling with sleep disordered breathing, obstructive sleep apnea, et cetera, airway issues. And their conclusion was that no one monotherapy, there's no sort of magic bullet here, that there's no one thing they can say they recommend that is really the end all be all. Now, people ran with that online and are saying, oh, look, there's expansion, palatal expansion is, which they never said it was ineffective. They didn't say many of these were ineffective. They just said in and of themselves are not going to be always effective, which again, people in my circle, no one's ever said they were. So what are your thoughts? Because a lot of people took this and tried to, I went online and tried to explain what I just said here about, they're talking about monotherapies. We don't have a magic bullet for this. We don't have a magic wand. We can say, oh yes, if you get tonsils and adenoids out, or if you go for expansion. That's the whole thing we started talking about at the beginning of this episode, was the need for us to be doctors and diagnose the patient. So what are your thoughts?
So, look, I think the biggest mistake that we've made is we've taken an aggregate of very different underlying causes of a disease, given that disease a name, and then given that disease a generic treatment model. When in actual fact, and this is something that I've been advocating for, and there's research papers advocating for, and that's what we call phenotyping. And what that means is explaining why the person has obstructive sleep apnea. Okay. And I mentioned when we're talking about the kids, we as ENTs, we first touched point on these kids because they had big tonsils and adenoids. So that became the paradigm for all of the kids. But of course, that doesn't work if their problem is due to obesity. That problem, that solution doesn't work if it's due to obesity. That solution doesn't work if it's due to nasal allergies. Right. Now, it might be part of the management, but if you don't fully assess and fully diagnose and fully treat, you're only going to get partial outcomes. Now, having said that, sometimes that's all we can get with certain, treatments. Yep. So, for example, with obstructive sleep apnea in adults, if they're a contributing factor to their disease is nasal obstruction, well, people say, well, if you fix that, it doesn't make the sleep apnea go away. And I go, no, that's okay. We've helped them breathe better. And by doing so, we have facilitated the use of nasal CPAP, or perhaps that's the one thing that was holding them back from tolerating a mandibular advancement splint. And we've now facilitated that. That's a great point. And differences between disease eradication, disease mitigation, and then basically disease, masking. Now, CPAP, which is the stated gold standard of management, really came about because nothing else was working. Surgery wasn't enough. The mandibular advancement splints in their early days weren't enough. And CPAP was the one that seemed to really be getting the best at results. So it was the one that climbed to the top of the tree back in the day and is called the gold standard of therapy, which is all well and good and said, but given that 2/3 of people or thereabouts are not using it after 12 months of being introduced to it.
Is that the number? 2/3 after 12 months aren't using it?
Yeah.
Wow.
Yeah. So it's a great therapy that most people don't use, which makes it ineffective at a population level. It's very effective at an individual level that uses it, tolerates it. But at a population level, it actually makes it an ineffective therapy. And what's interesting is if we look at, for example, mandibular advancement splints, we're talking about the adult population here, obviously. A lot of those adults tolerate it and will use it far more. So in terms of the overall treatment outcome, mandibular advancement splints have a better treatment outcome at a population level than CPAP does, not because a mandibular advancement splint is better than CPAP, it's because more people will use the splint. So, if you have, 60, 70 people using one therapy and 30 using another, well, the one that's being used more is going to have a larger group effect across a population. And the other thing I think that, I find interesting and, misleading and confusing and all of the above is that when it comes to CPAP versus mandibular advancement splint, it's like there's warring factions arguing over which is, going to be the one. But the reality is there is definitely a cohort of patients that benefit from combined therapy.
Right.
And the reason for that is, again, it's a bit like, what I said about unblocking the nose facilitates things. Well, if this person with the obstructive sleep apnea, if one of their dynamics is that their lower pharyngeal area is collapsing, and that is lessened by having their mandible advanced, well, that's a whole lot of heavy lifting that the CPAP then doesn't have to do, because the CPAP has to first blow the airway open and then blow something through what it's opened. If you put a splint in, then the CPAP doesn't need to have the pressures that it needs, and that in itself can lead to better acceptance and tolerance by patients. So the whole sort of thing is to say that a monotherapy doesn't work is kind of like stating the obvious.
Right. That's how I felt.
It's kind of like we just want to highlight that nobody should be saying that one thing fixes all.
Right.
And CPAP doesn't fix anything.
Right.
As soon as you stop your CPAP, your disease is still there.
Yep.
If we do surgery, well, look, you might still have your sleep apnea, but it might be a lesser form of it because we've relieved anatomical obstructions. And if you have a mandibular advancement splint that people use more than they use CPAP, well, that makes that therapy more effective for that individual because something is better than nothing.
Right.
So it's really interesting how people can want to construe things to agendas. And just because something doesn't work as we define working, it's being eradication of disease and elimination of all the same. Well, we have scenarios where we don't get rid of diseases, but we can reduce them so that they don't have as much of an impact on an individual as they would otherwise.
Right.
So that's the difference between treating a problem and curing a problem.
Yep. Yeah. I love the way you state that so clearly. So thank you for explaining that so clearly. It's much better stated than the way I typically state it. So thank you for that. And I also, on that note, I see so many people will post articles online, and we can cherry pick literature for really any purpose, but they'll post articles online and they'll compare expansion to tonsil and adenoidectomy. And I'm like, if you compare expansion to removal of tonsils and adenoids as, like you said, as monotherapies, to me, the whole premise of the study is flawed. And then they use, on top of that, to take it to the next level, they use AHI as the barometer for whether or not this helped kids, which we've already been down the path of the fact that that's a very inaccurate reading. So you basically, yet the conclusion that they draw from that is, oh, look, see, expansion. And actually in this particular paper I'm referencing, which was within the past, I think 6 months, it was someone who put it online and they were saying, see, look, adenotonsillectomy is really the gold standard and really does better than expansion. And I shake my head because I'm thinking they are just totally missing the point here. I want to play what you just said and be like, listen to this.
Well, it does better if they've got big tonsils and adenoids. It doesn't if they don't.
Right. Another good point. Right. Yeah. Yep.
Like I said, we're talking about a disease in its generic form. So it's like when I do the talks and seminars, I go, like, this person has obstructive sleep apnea with an AHI of 14 and hypoxic drop down to 89%. What does that tell you about why that person has the disease? Nothing at all. But if I say this person has a BMI, body mass index, of 37, suffers from nasal allergies, is regularly congested and mouth breathing, has a history of recurrent tonsillitis, and on clinical exam has large tonsils, suffers from reflux and has lingual tonsil enlargement, has pharyngeal collapse that is not responsive to mandibular advancement. What does that tell you versus what the first version?
A lot about the etiology. Yeah.
A lot. And those two people could have the same sleep study result.
Yeah.
That's
such a great point.
We're telling about. And the difference is, like I said, it goes back to that phenotyping. Because what do we know about that person that I described? Well, we know that person, we need to work on weight loss. We know that person, we need to deal with their nasal allergies. We know that person, a mandibular advancement splint is not going to work. And we know that they've got reflux and they've got big tonsils, and there might be some, surgery stuff in the mix, but we've got medication. We've got a whole disease spectrum in that person.
Yes.
That if we want to fix them, we got to fix them adequately and properly with the right tools at the right time for the right reasons. Now, some of that might be ENT surgery, but to be honest, most of that's going to be a waste of time when they've got a BMI of 37. So we need to work on weight loss. That's the big one. Everything else is side issues in comparison to that. So this is all about treatment planning, treatment structuring around the individual. And if we had 20 of those people and we gave them mandibular advancement splints, well, we would prove that mandibular advancement splints don't work.
Right, exactly.
In those people.
Yeah. And the same thing is the battle I fight on the expansion side all the time, because I've never said you just expand somebody to fix their airway. Never. And the people who I teach and talk to and communicate with on this, they don't say that. What they're saying is, like you just said with the patients on the otolaryngological side, look at what is causing the obstruction. Look at where they're having a problem. And in my world, if they are narrow and transverse deficient and deficient maxillary width and high vaulted palate and caved in mandibular arch and insufficient tongue space and retrognathic maxilla and or mandible, well, then there's things you can do to address that. But like you said, you have to look at the fact that if you take that patient and just remove, let's say they have enlargement of their tonsils and adenoids as well, and you just do the ENT surgery, well, that patient still has a lot of other associated factors that you're ignoring. And you could say, to your point, maybe 6 months later, and I saw this a lot in my practice, those patients relapse. And next thing you know, the parents say, they were doing better for a little while. Like after the surgery and they healed, a couple of weeks, like a month or two in, we really thought we were making progress. But you know what, Dr. Mike, this would be like at their first visit with me. They would say, they got them out in the last year. They'd say, we thought we were doing well. I had one particular case. Dad was a physician. He was an ER doc. And he was so frustrated because he had the patient, she had her tonsils and adenoids out. They thought they had it. And about a year later, she's back snoring. Not as bad as she was before, not as severely, but she was back snoring. She was back with some behavioral things. And this girl had no room in her mouth and for her tongue. So narrow. And I said, well, tell you what, let's go in and normalize the anatomy of the mouth. Let's go in and grow the jaws. And I did this and it transformed this girl's life. And Dad is literally saying to me, I can vividly remember it. Dad is like, he had a very strong personality. And he was like, why are you the only one doing this? Why is no one else thinking this way? And I just said to him, change, like we started by saying, change is hard. It's hard.
Yeah. So look, I think, like I've highlighted many a time and repeat again, I'm not a dentist or an orthodontist, but but I'm very much aware of the skills, the importance, etc. of the same. And the way I look at it in terms of treatment planning these cases is that there's two stages in this person's life. The first stage is while their jaw is growing, and the second stage is where their teeth then end up down the track. And as far as I'm concerned, you want to optimize the jaw young and early, and we keep pushing things back younger and younger, and people are horrified that we're doing expansion in 4, 5, 6, 7-year-olds. That, you can watch that jaw grow for a bit, and that jaw is not, spontaneously going where it needs to be in a reasonable time frame. You don't want to leave that child with that jaw into adulthood, because basically that sets them up as being predisposed to, not condemned to, but predisposed to having obstructive sleep apnea as an adult, and opens the door as one of their treatment pathways being orthognathic surgery. So if you were to tell a parent, hey, look, here's your 5-year-old, this jaw's not growing properly. Now, we can do a little bit of stretching and expanding just to get it into place now. Or if we leave it and it doesn't sort itself out, then these are some pictures of the jaw surgery they'll need later. Every parent, bar a few, is going to be signing up for that expansion to go, well, of course, it makes sense. But do it when the jaw has been optimized first. And do that early. Not only because it's going to, lead to, people say, oh, well, that means it's 2 lots of orthodontic treatment. It's just like, well, yeah, but they're for different reasons. One's for the jaw and others for the teeth.
Right, so, exactly. And people get that. When I would explain that to my to parents, I would explain that in just like you did. And parents get it. They're like, especially when you show them the images and take the time to go through in the treatment planning stages, they get it. They understand that their child has these other issues. And then go ahead.
Yeah, and you're being honest and you're setting the expectations. You're saying, look, I'm going to get one thing sorted now. There's going to be some other work later on, but this is all part of the big picture. And if we do this primary stage of treatment, the secondary stage is going to be a lot easier because I'm going to be working with a much better canvas down the track versus leaving this all to, try and salvage. When I don't have the room, I can't make the room. And then, I've got to compromise and remove teeth, which, is going to get you the aesthetic result that you want, but it's not going to give you a functional result down the track that is, in the best interest of your child.
And a lot of times the aesthetic result, when the structural is not right and we've camouflaged it by removing teeth, I always say, too, people are always like, oh, you say that, do you think extractions cause airway problems? I always say, no, it's not like you extracting teeth is causing the airway problem. The problem was already there. By treating it with extraction, you're ignoring the problem and you're treating the symptom of the fact that the teeth are crowded. Like I don't know why this is so complicated.
Well, and it also then follows through, like I said, with the fact that, and again, it's not a criticism, it's a reality. In your orthodontic training and then even in your orthodontic practice, you don't see these people when they're 30, 40 years down the track from what you've done. You don't. And then you just pause and go, all right, what are the risk factors for having obstructive sleep apnea from a dentoskeletal point of view? It's a narrow maxilla. It's a retruded upper and lower jaw. When did those things happen?
Right.
In childhood.
Right. Not when they're 50. Right.
They haven't gone from, wide arches to a collapse.
Right.
In their latter ages of life.
Correct.
That led to the sleep apnea. What's happened is that they were set up for failure. There's been some other things that have come along, and because they were closer to the edge of the cliff, it was easier for them to fall off, premature to what might have happened otherwise.
Yep.
So you're absolutely right. The whole, extraction versus non-extraction. Look, there are cases where you need to extract.
Right.
It's not like it's an absolute dogma.
Exactly.
But if you can get in early and improve those jaws, then at least you're creating a better opportunity for saving the teeth down the track. So that's how I see it as an ENT that's not a dentist, not an orthodontist, but can make these observations. And I see these, patients, in their adulthood, and I see their jaws, and I just go, what different life could have this person had from a health point of view? They've got anxiety, they've got depression, they've become obese. I just go, how much of this is that this person was just set off for the wrong road and just slowly meandered down to, the point now where I'm actually seeing what is effectively end-stage disease of years of progressive deterioration.
And on that note, to close out, ironically, maybe fortuitously, in the time that we were taking a little break there were some comments on my previous episode with Lauren Gates about Lauren made a comment, which I agree with, that to your point with end-stage disease, she was saying that we need to realize as a profession in general, or as kind of a medical dental profession, and as a group of us need to come together and say, okay, we are dealing with end-stage disease when we're talking about obstructive sleep apnea, just like analogous to, not equal to, analogous to stage 4 cancer. It's end stage disease. It's late in the game. That patient you just described, is really, really hard to undo everything that's going on. We want to get this patient when they are at analogous to, say, stage 1, right? We want to catch it early. We want to get them young. We want to get them when we can grow the bones and develop the bones, and they can go through an otolaryngological surgery and have really good results and quick healing and minimize the morbidity of it. And so people online were just going off on that when I posted the episode. And you know what, David, that really bothered me? They were laughing about it, like all laugh emojis to the fact that she made this comment and mocking the fact that she said that. And they're like, well, we could compare it to a lot of things, but stage 4 cancer. And I said back in the group, I said, I think we need to be careful here. I said, because first of all, she said she was drawing an analogy. She didn't say it is stage 4 cancer. She was drawing an analogy, as I just explained. Secondly, people lose their lives to obstructive sleep apnea. There are people, and I had one of them, Stacey Becker, on my show, and I actually posted a link to her episode with me from a year ago, where she tells the story of her dad who lost his life to OSA. And I was really shocked. So I said on there, I said, well, I've got an ENT. It's going to be in next week's episode, and we'll have to hear his thoughts. So what are your thoughts about that?
It's an analogy.
Yeah.
I mean, let's look at this big picture. So stage 4 cancer is basically the worst of the worst.
Yep.
And the reason that we have things in healthcare for certain cancers is we have a screening program, is because we know that if we pick it up early, the investment that we put into that screening by picking up these things early leads to the identification of disease at an earlier stage, which is much easier to treat and fix. I gave you that example. We've got the person, if I rewind, who's got a BMI of 37, who's got allergic rhinitis, has a history of tonsillitis, and the like, and has got reflux. Well, how many of those things could have we picked up and sorted out well beforehand? Well, we could have had a focus on wellness and diet and exercise and mitigated lifestyle measures to some degree to pull back from the obesity.
And I'll add to it transverse deficiency and retrognathic mandible, just to throw that in there on them as well. Right.
Yeah. And that could have been picked up in childhood.
Right.
The nasal allergies could have been picked up, and rather than just dismissed as just allergies, could have been, managed appropriately.
Right.
And then the reflux could have been controlled, and the tonsillitis, could have been mitigated against one way or another. So I totally understand the analogy is saying, look, we're trying to fix something like that. Why are we setting ourselves up for heavy lifting and hard work when we could have had a whole range of other things done at the right time, so that the allergies were managed by the allergy doctor, the ENT problems were managed by the ENT, the orthodontics were managed by the ortho. We could have got in early and been proactive. And that's no different to the mindset of cancer.
Right.
Cancer, if we unfortunately and realistically look at what progress have we made collectively in the management, control, and the like of cancer, it's not much.
Agreed.
We've got, it really is not much. So we really, the biggest difference is catching it early.
Yeah. I was waiting for early diagnosis is the key.
Yeah. That is the biggest dynamic.
Yep.
So that's how I understand the analogy. Is just like, look, why are we waiting for these people to be so bad that they have obstructive sleep apnea, they have high blood pressure, they have diabetes, and they've had a car accident already? Why are we waiting till then? When we can be at the grassroots level doing some screening and so forth for everything. So, like the touch point, at the doctor's visit for, when they're getting their flu shot can be, need to ask you about breathing and sleep.
Yep.
And then specifically, I want to know, anyone said that you stopped snoring? Do you feel like your sleep quality is impacted? Can you breathe through your nose okay? These are not difficult questions.
No.
And the assessment from an ENT point of view is not difficult. The assessment from a dental and orthodontic point of view is not difficult.
No.
And to even highlight the point, we know that obstructive sleep apnea worsens the prognosis of certain cancers, breast cancer, colon cancer, melanoma. So even though it was an analogy, it's actually quite apt, in the context of obstructive sleep apnea, because it's a really pernicious disease. It causes cardiovascular disease, it causes metabolic diseases, and it makes cancer worse. Right. So often what comes about these things, let's be honest, social media is social media, and people are going to have their moments of whatever they want to sort of, make upbeat about themselves. But Lauren, that's a perfect analogy as far as I'm concerned, because that's just highlighting the absolute crucial element from a medical point of view. And that's where I think some things get lost sometimes, is that, obviously, Mike, you're a little bit different from the crowd, but, if your job is teeth, all right, well, you don't really buy into a lot of the other things that, are connected to the same, then you're going to be dismissive of the same. And if you don't understand it thoroughly and appreciate the importance of early treatments, early interventions, and then the life-changing elements that flow on from that, well beyond that, this person's going to be in your clinical care. Well, look, some people are just never going to change their minds.
Yeah.
And the problem, unfortunately, is that, a lot of, the education that is out there is really contingent and founded upon the individual and how much they are hanging on to what they were taught and what they believe versus what has changed. And that, again, is just totally reflective of, how we started out this chat. Is it just talking about, like me, I thought taking tonsils and adenoids out of kids fixed every kid forever. And that was it. Full stop, done. I'm awesome and thank you all. That's not the case.
Right.
I was literally horrified, when I read the paper that said that 20% they still got residual disease straight up. And then of the 80% that do get better, 20% of those relapse in due course. So you got to wake up to that, and you got to go, well, I'm not as good as I thought I was. I'm clearly not getting the best outcomes here by just doing the generic surgery for the generic diagnosis. So what am I missing here? And what do I need to improve on? So I started focusing more on the nose, and then I trip into the dental world and this whole thing of expansion and so forth. And then myofunctional therapy starts. All these words that, again, just to highlight, 16 years of medical and specialty training, and never ever heard these words.
Yeah.
Never, not once. Expansion.
I mean, if you ask the average orthodontist what myofunctional therapy is, they can't even define it. And I'm not being critical, because if you asked me, 5 years ago, I couldn't either. So
no, yeah, absolutely. So, but the thing is that when you're introduced to it, you've got two choices. You can dismiss it outright, or you can go, well, hang on a sec, this is new and different. Before I just throw this one into the stupid pile, like all the other ones that I've, done automatically. Let's just look at it for a moment. What's inside of this box, and what does it have, and what does it deliver? And does it blend in with what I'm already thinking and doing? And does it make sense? And then, all right, let's delve into the science a bit more. What effect, is this having? Myofunctional therapy, perfect example. AHI reductions. It's no different. Like going back to those studies of the didgeridoo, the Australian wood instrument.
Right. Yep. Isn't that like pharyngeal tonicity or something with that was greater?
Well, the irony is that the research was done in England.
Okay.
So that study was National Health Service, where people were on a wait list for a CPAP machine.
Okay.
And because there was a delay, what they did is they said, look, we're going to teach a group of you guys how to play the didgeridoo, just on the off chance that this sort of breathing exercise and training might do something. And it did. It reduced their AHI by about half. So and then that's been replicated in studies such as in wood instruments wind instruments rather. So things like playing the trumpet, playing the trombone, the tuba. Those people get great pharyngeal tone. In the UK, singing therapy is a recognised treatment for obstructive sleep apnea because of the same thing. It's improving your throat tone. These are all just variations on the theme of exercise.
Right.
Whether you run, whether you do HIIT, whether you do, Olympic lifting, they're just variations on exercises. And people go, oh, well, which one's better for you? And so it's like, well, you know what? Doing a bit of everything sometimes is good for you. And I think it's the same with these treatments. A bit of everything is good. And again, it highlights, again, that the perfect analogy with the cancer is sometimes, there are times where, we can cure the disease, and there's some times where we just can control it.
Yep.
And there's times when it will relapse. So, that concept of thought is really appropriate. And I think the pushback that came from that is very similar to the pushback that I got back in the early days when I started highlighting that this is brain damage that these kids are getting. And you're like, oh, you can't say that. This is fear-mongering. So it's like, well, is it really? Right. Or is it just being truthful? Right. And in time, you look at the literature, within the literature, they are using the words brain damage. Even within the title of the papers, they are now saying brain damage. Because we've really got to the point where, enough's enough. We've got enough science, we've got enough knowledge, but we don't have enough permeation into the public mindset, the public awareness. And, pediatric sleep disordered breathing, it's far more common than asthma and diabetes in the pediatric population combined. It's far more popular. Wow. Whereas I guarantee you and I just walk down the street and say, hey, I just want to get your feedback, from random people. What do you know about pediatric sleep disordered breathing? They'll go, I know what you're talking about.
Right.
And they go, oh, what do you know about asthma? What do you know about diabetes? They'll have some insights and awareness and knowledge.
Right. Yeah.
So those words and diseases have permeated into the culture, whereas this one hasn't at all. And because that's the case, it's very much dismissed at a public level, and then it somewhat gets dismissed at a healthcare level too.
Yeah.
And this is what needs to change. If we need to at times, I guess just be a little bit blunt and use these words that trigger people at times into certain reactions. Well, look, I think it's a testament to their professionalism as to how they react.
Yeah. I couldn't agree more. That's such a great conversation. Dr. David McIntosh, I so appreciate you, all your work, your books, your time, your energy, your enthusiasm, your passion for this. You're helping really, really push that concept further down the field so that the public is getting educated. You're doing more than just doing it for your patients. You're educating, and you're getting out there. You're taking the time to come on a show like mine and give my audience all this time. And that's how this message spreads. That's how we keep doing it. I have so many people that reach out to me and say, thank you for just raising awareness. And what you said there is so key. We have to keep raising awareness. And I just can't thank you enough for your generous time and for your knowledge and expertise and skill and passion for this. Really, it's been an absolute pleasure.
Well, likewise. Thanks again.
All right. Thank you.
All right. Cheers.
Bye.
Thanks. Bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.